This is a presentation of the Hughes RiskApps Breast Cancer Risk Assessment System. We're the global leader in software for cancer risk assessment, and our mission is to identify high-risk patients for screening and prevention and to improve patient care and outcomes. The software was developed in 2006 at Massachusetts General Hospital as a guidelines-based breast cancer risk assessment tool. In 2007, Newton Wellesley Hospital was the first site live, and today we have 70 facilities around the world, including teaching hospitals, genetic counselors, and mammography centers live today. Hughes RiskApps was spun out as a private company in March of 2014. With regard to MRI screening, that is one of the goals of the Hughes RiskApps software to help identify women who may benefit from additional screening, and this is typically high-risk women. If you look at the 40 million women who receive mammograms every year, 15% of those women would meet American Cancer Society guidelines for mammography screening, and yet in actuality the number screened is significantly lower. Typically 0.5% of the mammography population actually receive an MRI. Our medical advisory board consists of thought leaders in the field. Dr. Hughes, who is one of the leaders in breast cancer risk assessment, Daniel Copans, one of the leaders in women's imaging, both in terms of tomosynthesis, ultrasound, CT, and breast MRI, Mark Lipman, Dean of the University of Miami Medical School and formerly head of the medical breast cancer section at National Institutes of Health, and lastly, Giovanni Parmigiani, a creator of the BRCA Pro risk model and a leader in breast cancer risk modeling. Over and above our software, the Affordable Care Act speaks directly to the issue of capturing family history and risk factors with regard to patient health. In fact, the Affordable Care Act Meaningful Use Phase 2 states that family history must be taken into consideration when assessing treatment plans and screening. That said, many of the guidelines and models for guiding care and screening are very difficult for physicians to use and are only used sporadically by doctors. The Hughes RiskApps solution develops usable tools that fit easily into a practice's workflow for guideline-appropriate care. So, the way it actually works is patients can enter family history and risk factors on a tablet computer or even via the internet. Risk calculations are done using standard models, and guidelines are made according to established guidelines. The goal of all this is that high-risk patients receive screening, and in the case of the mammography population, potentially breast MRI. Just a snapshot of one center looking at how many women actually met the American Cancer Society guidelines, which are greater than 20% lifetime risk of cancer. At Newton Wellesley Hospital, they looked at a study of 10,000 patients, and nearly 15% had a greater than 20% lifetime risk of cancer. So those women meet American Cancer Society guidelines for breast MRI. To look at a slightly bigger study in terms of actual utilization of MRI, in the large Wormley study, 1,300,000 women were looked at. In that study, only a bit under 9,000 women were referred for MRI, which is 4.3 per thousand. Ironically, of those women who got MRI, 75% did not meet the guidelines. So they were drastically under screening, and the folks who actually got the MRI were not the correct patients. So our system automates the entire process of identifying women who are at high risk and recommending additional follow-up for those patients. Individuals can be tracked for compliance and receive follow-up letters automatically. Follow-up letters can also be sent to their PCP, whether that's an internist or an OBGYN, with recommendations for follow-up for that patient. Here's a sample also of a letter of medical necessity. If additional studies are needed, we can also automatically generate a letter of medical necessity to the insurer. The goal of all this is that women will finally have the screening and prevention they need to prevent needless cancer deaths. With no further ado, I'm going to actually transition over and show you a working version of the Hughes RiskApps risk assessment software. So here we are in my imaginary clinic. I'm one of the support staff, and a patient just walked in for her mammogram. and we're going to hand her a tablet computer and ask her to complete a brief risk assessment. So here's her name, her date of birth, and we're asking her, is this your name and date of birth? Is this the correct patient? She says yes, and we forge ahead. Our imaginary patient has a glass of wine after work every day. She's a smoker. We're capture the date of first period, and we're going to intentionally make this patient on the high risk side so we can see the follow-up that the software recommends. We're going to say she's never been pregnant, her height is 5'5", and that she weighs 155 pounds. We can toggle to different languages on the fly: Spanish, French, Portuguese, etc., or back to English. The results of the survey are automatically translated back into English for the clinician. This particular patient has not had a biopsy, although if they had, we can capture the diagnosis of that biopsy. And this patient also has not had implants. The implants issue is not directly relevant to the risk models, but in breast health, it's a relevant question to ask. In order to increase this patient's risk, we're going to say that she had a history of chest radiation and that she currently takes birth control and began taking it at age 17. She took birth control for 20 years continuously, but never took fertility drugs. We'll say this patient is Caucasian, is not Latino. Actually, folks of indigenous Latino origin are actually at reduced risk of cancer. We'll also say that this patient is not of Jewish descent, which would actually increase risk. Have you ever had cancer? So we're going to say yes to this patient. We're going to say that she had a history of lymphoma, which explains this particular patient's chest radiation treatment history. And she was diagnosed at a fairly young age with lymphoma. Now we're also going to capture blood relatives who may have had cancer for this patient. We'll say that the sister, if we said the sister had breast cancer, that would automatically make the patient high risk in any of the models. We're going to say ovarian cancer, which is almost as relevant to risk. And she had ovarian cancer when she was 28. We'll also say that the maternal grandmother, a second-degree relative now, had a history of breast cancer. She had breast cancer in one breast at age 35. And now we're going to capture the father's side of the family. We're going to say a grandmother and a grandfather had a history of cancer. Again, I'm intentionally boosting risk, so I'll say the paternal grandmother had a history of breast cancer in one breast at age 29. And notice that the gender, when the gender changes for the relative, the type of cancer you can get changes. A male can still rarely get breast cancer, but ovarian is gone, and now we have prostate as an option. So we'll say the grandfather had prostate cancer at age 62. Have you had genetic testing? For that subset of patients that have had genetic testing, we can capture their BRCA status, or we can even look at considerable number of other markers. I'll say no for this particular patient. And we're done. We can also capture this patient's email address for follow-up, and the patient is completed. The next message the patient would see is to please give the tablet computer back to the desk. In my demo system here, we're actually going to run my risk models in the background. It's running the BRCA Pro model right now, and it'll blast through and run all the risk models based on the survey answers that this patient has put in. My models are done, and we see the message that the patient would typically see, return the tablet computer to the front desk. The patient would never see the risk models running. So I'm going to quit out of the patient interface here, and we're going to see that the system automatically generated some smoking cessation information for me because the patient said she was a smoker. Likewise, the system automatically generated some follow-up information for me. Here's a letter back to the referring physician stating that according to National Cancer Center Network guidelines and according to American Cancer Society guidelines, both guidelines recommend MRI of the breast if a patient has a lifetime risk of greater than 20%. That's a lifetime risk of breast cancer. And in fact, according to the Tyrer-Cuzick model, this patient has a 28.9% lifetime risk of cancer. We also told the attending physician that we've attached a letter for the referring physician to use with the insurer if they want to get pre-authorization for an MRI. If I want to drill down a little bit further, a clinician can also look at the full risk survey summary on that patient. This is what a radiologist or an OB might see if they want to do a bit of a deep dive on a particular patient. We see all the recommendations that the system made. In fact, this patient has a greater than 10% risk of mutation, so the system recommended genetic testing. The system recommended MRI because this patient has a greater than 20% lifetime risk of cancer, and it also recommended MRI because this patient has a history of chest wall radiation under the age of 30. We also can see all of the answers to the questions that the patient answered, scores on all of the various risk models, BRCA-Pro, Tyrer-Cuzick, Gale, Klaus, etc. And we even had some scores on some colon cancer risk models as well. This system also creates a pedigree, a family tree for that patient on the fly based on the information entered. When a survey is completed for a patient, we can also take a deeper look at a particular patient's risk history. Anybody who's high risk automatically becomes part of our high risk queue. We can track them for follow-up. We can track them as to whether they got genetic testing or a follow-up MRI. We can pull a particular patient into our risk clinic and do a full-blown pedigree. We can add additional relatives. We can resize the pedigree, and we can add at the pedigree level various cancer histories to individual family members, which will then populate back to the database. We can also take a look at the actual risk history for a particular patient on the various models, how their risk calculates over time, and we can see mutation risk for any family member in the pedigree from the family history as well. So this is both a comprehensive screening tool that a patient can interact with in order to capture their family history, but it is also a full-blown risk clinic tool for genetic counselors to do a deep dive and do a full-blown family history. If a genetic counselor is involved, we would also capture both affected and unaffected relatives and do a much more in-depth risk assessment. In a screening environment, we just do the quick basic risk assessment and assume that the high-risk patients will get additional follow-up. The system also has comprehensive management reporting, tracking of BRCA-positive families, and can track Lynch syndrome patients and patients who may not have a greater than 20% lifetime risk of cancer, but who are at least at high risk of having a BRCA mutation. That's a fairly complete presentation of the Hughes RiskApps software. Thank you for joining us.